Hello, ladies and gentlemen, dear dentists and teeth enthusiasts. Thank you very much for spending your precious time here with us at IDS and especially here at our Speaker's Corner. It's 12 o'clock and that means we are ready for our next presentation. Periodontitis. It affects almost 1 in 2 people worldwide and is considered the most common chronic inflammatory disease of all. But while we have mainly been fighting bacteria up to now, research is showing a new way. Targeted control of the inflammation itself. Experience now how innovative approaches could revolutionize the treatment of gingivitis and periodontitis by, and he's already prepared and ready to go, the Vice President for Clinical and Translational Research at ADA Forsyth Institute, and he's also a professor at Harvard. Please give him a big round of applause for Thomas van Dyke.
Well, thank you very much. It's a pleasure to be here, and I want to thank you all for coming. Today I'm going to talk about a new product, which I think is very exciting because it changes the paradigm of how we treat periodontitis. As you will see, we've been treating periodontitis the same way for roughly 60 years, and we are not anywhere near controlling or curing the disease. So the product, IsoDent PARO, controls inflammation naturally. So we think this is a revolutionary as well as patient-friendly treatment platform for periodontal diseases and importantly other inflammatory diseases, placing emphasis on the oral health, systemic health connection that we've heard about a lot during this meeting. As we know, there is a huge unmet need in terms of perio. As was just mentioned, 1 in 2 people in their lifetime experience periodontal disease, and in the elderly population, or the aging population, over 65 years of old, it's like 70% of the people have periodontal disease. There has been little medical innovation in the treatment of periodontal disease in the last 60 years. Periodontists generally do surgery to correct the problem, and basically it's reductive. It's very difficult to regenerate lost tissues, and our understanding of why that is now evolved significantly. So the revolution here is the treatment target. We have focused on the etiology of the disease for the last 60 years, but in that 60 years we have discovered that the pathogenesis of the disease is actually all inflammatory. And it's been reclassified by all the major periodontal organizations in the world as an inflammatory disease. Thus, the treatment target that we're going to talk about today has changed. We're talking about treating inflammation to treat the infection. So, PARO is a simple and safe and effective health solution for individuals who suffer from periodontitis and other inflammatory diseases. And it's very, very important to note that while this is a medical treatment, we're controlling inflammation. There are no side effects whatsoever. And I'll explain why. So just quickly, the problem is a very large disease population. There's a significant unmet need, and left untreated, inflammation causes severe health problems systemically, not just in the oral cavity. We have what we consider now suboptimal treatment options. Surgical interventions are very expensive. They don't provide robust safety, efficacy, and adherence by patients, and there's a very high disease recurrence. Our solution is actually a novel, simplified approach. It's a daily mouthwash that's safe and effective. It is approved as a Class 1 device in the European Union. And it fills all the MBR regulations. There's a significant differentiation in that the mouthwash treats the entire oral cavity, not just site-specific, and it also treats you systemically as well, because the compounds are absorbed. as I will show you, we have very positive clinical study results, and the platform is completely safe. This research came out of years of work. This is the team who has been working on it. Dr. Sirhan, who's a Harvard professor, discovered the molecules that we use, which are naturally occurring in everyone's body, and they drive resolution of inflammation. They do not inhibit inflammation. My team includes Dr. Alp Kantarci and Hatice Hazturk from the ADA Forsyth Institute, and myself, and as you can see from the number of publications and et cetera, that we've been doing this a long time. So, as I mentioned, the important take-home message here is that periodontitis is an inflammatory disease. It is a gram-negative infection. The bacteria cause the inflammation, but they're not the target of treatment because they're commensal organisms. You cannot sterilize the oral cavity. So the relationship between the inflammation and the bacteria becomes central to what we're trying to do. And as it turns out, the inflammation is actually what drives changes in the microbiome. It's not the other way around. Early colonizers in the oral cavity will cause inflammation. Most people, that is easily controlled by brushing your teeth. But in about 10, 15, 20% of the population, they have excess inflammation. And the question is, why do they have excess inflammation? We think we understand that, and we think we have provided a solution. So, although inflammation is protective and the normal inflammatory response is physiologic, when it becomes excessive and chronic is when we end up with chronic inflammatory diseases. Now, chronic inflammatory diseases in the oral cavity include periodontitis, erosive lichen planus, and et cetera. But all the major diseases of aging that we suffer, including cardiovascular disease, type 2 diabetes, Alzheimer's disease, arthritis, are all inflammatory diseases. These are non-communicable diseases. So failure to resolve inflammation is the key. So the idea of uncontrolled inflammation and disease has been around a long time. Just quickly, I'll show you on this slide. But in prior decades, we focused on rheumatoid arthritis. This was like the poster child for uncontrolled inflammation. But what we've managed to uncover in the last years is that periodontitis is included in this, as well as other systemic disorders like diabetes, cardiovascular disease, Alzheimer's, and arthritis. So the question is, what's the mechanism that underlies resolution of inflammation? So I'll spend just a minute on this slide because it's critical to the message. On the left-hand side, we see a normal acute inflammatory response. And what you see is that there's an activation phase and there's a resolution phase. We used to think that the resolution phase was the result of the passive decay of pro-inflammatory signals. The discovery that was made by Sirhan some 20-odd years ago now is that resolution of inflammation is actually an active process. Okay, that means that the body produces molecules that he isolated by analyzing inflammatory exudates throughout an acute inflammatory response. So as you see there at the peak of the normal inflammatory response, he discovered the emergence of something he called active specialized pro-resolving mediators. These are the molecules, they bind to specific receptors on cells. They don't inhibit inflammation. They bind to receptors on cells, and they change the phenotype of the cell and drive resolution of inflammation. They are essentially where prostaglandins and cytokines are the on signal for inflammation. SPMs are the off signal for inflammation. So when we have chronic inflammatory disease in the panel on the right, we have an activation phase that's normal, but it never resolves. Okay, so this is the excess inflammation that becomes chronic, and it appears to be due to a failure of the resolution process that is supposed to naturally occur. What's important to note is if you have this inflammatory process, you're in chronic inflammation, you have the horizontal parabolic curve as you see there. If you add SPMs at any point along that chronic inflammatory lesion, you immediately return to homeostasis. So this basic observation is the basis of IsoDent PARO, which provides the off signal and returns tissues to homeostasis. Okay, so we are able to basically resolve periodontal disease, as I'll show you in a second from the clinical trials. So it's a simple application. It's a daily mouth rinse. You only use it once a day. You swish for 60 seconds. It's safe and efficacious. And what's critical here is the unique mechanism of action. This is totally unlike any anti-inflammatory drug that's on the market. All anti-inflammatory drugs inhibit inflammation. Inhibit being the key word. They block enzymes, they block receptors, and when you do that, it's a very non-specific inhibition. So you have a lot of side effects. For instance, the original observation that periodontal disease is probably an inflammatory disease was made 40 years ago in the early 1980s using non-steroidal anti-inflammatory drugs. It was a great discovery. However, there was absolutely nothing we could do about it because if you took a non-steroidal anti-inflammatory drug for more than 3 weeks, the side effects became, in some cases, life-threatening. So that whole idea was abandoned, and we went back to trying to control the bacteria. Now we have a solution. So the product itself was launched about a year ago under the CE mark. It's offered in 3 strengths. Mild is intended for prevention of gingivitis. Medium is intended for the treatment of gingivitis. And the strong, the highest concentration, is intended to treat periodontitis. So just give you an idea of some of the clinical trials that have been done. The first one I'll show you is a gingivitis trial. This is a 1-month trial using the mildest form of IsoDent PARO. And as I mentioned, it was 28 days long. Gingivitis was the outcome. There were 50 patients were treated with the product, 50 placebo. And there was also a no treatment group to determine what the placebo effect was from the rinsing by itself. What we see is that looking at the change in the gingival index, you can clearly see that the rinse performs much better than the placebo, as well as the no rinse group. So there is a placebo effect, as you can see, and there's also a Hawthorne effect. The Hawthorne effect means that when you enroll somebody in a study, they change their behavior. So you can see that here too. People get enrolled, they brush their teeth better, okay? So their gingival index goes down a little bit. But what you can see from this type of thing, and in this population, which was a gingivitis population, there were also people who had periodontal disease. And so we evaluated the periodontal sites in this study as well. And mind you, this is a mouth rinse only study. There is no mechanical therapy, no scaling and root planing. And these patients who were using the rinse for 28 days exhibited a spontaneous reduction in pocket depth of 1.23 millimeters. Now, this is, on average, pretty impressive when you consider that 9 months of treatment with antibiotics with scaling and root planing, the reduction in gingival index was between 0.8 and 0.9, or reduction in pocket depth was between 0.8 and 0.9. The next study that was performed was a dose ranging study. The details of the study are on the slide. In this dose ranging study, the goal was to find what was the optimal dose of the compound for the strongest. What is the maximum amount of effect we can get for the minimal dose? Again, this is a mouth rinse only study. It was 3 months now. There was no intervention until after the study was over. And what you can see from the graph on the right is that the the peak effect was at 5 micrograms per mil, which is now the concentration in the strong version of the product. The medium is at the 0.2, and the mild you saw from the first trial. So we were able to, again, optimize the dosing with this study. But these contrived studies where you don't scale, it's not real world. So then we went out and recorded from practitioners actual real world outcomes. And this is an example of that. This is a report of a 54-year-old patient who's got moderate periodontitis. And this is over 3 months. Now, again, initial therapy was not begun until after 3 months of mouth rinse in this study. And you can see it started in November of 23, was followed up in December, and then this phase was over in March, and the patient went into routine therapy. But her requirements for routine therapy changed dramatically as a result of using the mouth rinse. What you can see is that the percent of bleeding sites at baseline was roughly 60%, which is what you would expect to see in a moderate periodontitis case. A month later, that was down around 30%. And then by March, so at the end of 4 months, it was 10%. Okay, so the mouth rinse alone is taking a moderate case of periodontitis and taking the gingival index from 60% to 10%. If looking at pockets, what we did here was we used a cutoff of 4 millimeters. As you have pockets more than 4 millimeters, you probably require further therapy. If they're less than 4 millimeters, you don't. So we use that as a cutoff for indicating what the patient would need next. And as you can see, the number of sites or percentage of sites with pocket depths of greater than 4 millimeters went from 60% down to 20% over the period of the study. And then the mean pocket depth at sites over 4 millimeters, you can see, went from roughly 5.5 to 3.5. And again, this is simply by controlling the inflammation with the PARO product. And then the last study I want to show you is related to another private periodontal office. This is multiple patients, 3 to 6 month follow-up of all patients. The patient age range was, as you can see there, 33 to 78, so it covered most age groups. 9 patients had moderate to severe periodontitis, 4 had very severe gingivitis, and the treatment included initial therapy. So now we're in real world. So the patient comes into your office, you do your diagnosis, you would initiate initial therapy and initiate use of the mouth rinse. And the way we've analyzed the data here is you can see in the gingival index, which includes all 13 patients that had gingivitis. Obviously, the periodontitis patients had gingivitis as well. You can see that the GI was pretty close to 3 to begin. So a lot of these people had spontaneous bleeding. But at the end of the study period for all of these patients, you can see that the gingival index was down close to 0.5, so well below 1, which is we're getting pretty close to no gingivitis at all. If we look at probing pocket depths in this population, what we're illustrating is the average of the deepest pockets in the patient, okay? So for each of these patients, their deepest pockets were recorded. You can see the average of those were 6.44 across the 9 patients. And again, at the end of the treatment period, so post-treatment of initial therapy and use of IsoDent PARO, the pocket depths were just over 3. So basically, we're taking people with moderate to severe periodontitis, and we are taking them into a realm where they become maintenance patients. Okay, so and then other observations and case types were reported by a series of practitioners across Europe. Some of them are listed here. Laser gingivoplasty is a popular procedure for recontouring the gingiva pre-crown and bridge or post-crown and bridge or post-orthodontics. These are, routine procedures. Post-operatively, they're not terribly comfortable if you've ever had one done. But what the practitioners are reporting is that if they use the medium-strength PARO post-operatively, the next morning the patients have no post-operative pain, and that the healing is almost complete in 2 days. So there's much more rapid healing with control of inflammation. Same thing is reported for anectomy cases, tongue-tied cases, no post-op pain by the second day, and accelerated healing. There were a couple of reports of oral mucositis in patients undergoing cancer chemotherapy and radiation. This is an interesting indication, but an interesting problem as well, because patients who do get oral mucositis as a result of chemotherapy often have to have the chemotherapy stopped because they can't stand the pain, they can't eat, and it becomes life-threatening. The use of the PARO product basically reduced the pain markedly so that the chemotherapy could continue and the ulcers actually started to heal. There is no treatment for that currently, so this is a very exciting finding. And then finally, in surgical cases, post-extraction or post-implant placement, the PARO medium led to much less post-operative pain and rapid, uncomplicated healing. So we think the time is now for a transformative medical treatment for periodontitis. It's safe, it's effective, and it's easy. And we encourage you all to join the revolution, if you will. And the booth, the IsoDent booth, is actually just up the escalator to your left if you'd like to stop by and look at more detailed and get some samples. But I'll stop here and open it up to questions for anybody who's interested. Thank you very much for your attention. Questions? Come on, it couldn't have been that clear. Okay, go ahead.
Hi, Janice from the States. And I get asked a lot. I coach and speak, and, pH is a big deal. So I will be asked, because I'm very excited about this great presentation, what is the pH of the mouthwash?
pH?
Yes.
7.
Perfect.
It's neutral.
Perfect. Thank you.
Yeah. It's actually very pleasant. That's why you should get a sample. It's quite nice. So. Anyone else? Okay, I'll be hanging around for a few minutes if anybody else has any further questions. And I thank you all for your attention. Have a great day.